lecture covers Chapter 29, Infection Prevention and Control. Infection is the invasion of a susceptible host by pathogens. The entry and multiplication of these organisms result in disease. Colonization occurs when a microorganism invades the host but does not cause an active infection. For example, many patients and healthcare workers are colonized with staph, such as MRSA. Often these patients will be placed in contact isolation and treated with CHG bath wipes and Bactroban ointment to the nares twice a day. Although these patients do not have an active infection, they might be placed in contact isolation. We will discuss this term in future slides. Communicable disease is if the infection process is transmitted from one person to another. If pathogens multiply and cause clinical signs and symptoms, the patient is considered symptomatic. If a patient is symptomatic, they might exhibit an elevated temperature, complain of a headache, chills, or nausea. Often individuals might have a viral illness but not know it because they're not having any signs or symptoms. This is referred to as being asymptomatic. Other diseases, conditions that may not elicit symptoms right away include hypertension or hyperglycemia. The effects from these conditions will show up at some point if the disease is not well managed. If clinical signs and symptoms are not present, the illness is termed asymptomatic. An important fact to remember is that hand hygiene is the most important technique in preventing and controlling transmission of infections. Infectious pathogens include bacteria, viruses, fungi, and protozoa. Examples of pathogens include E. coli or C. difficile. There's many more than that. The potential for pathogens to cause disease depends on their numbers, the virulence of the pathogen, survival, and host susceptibility. A reservoir is a place where pathogens survive, multiply, and await transfer to a host. It's a known fact that microorganisms like to reside in warm, dark, moist environments. Examples of reservoirs include the large intestines, a colon, oropharynx, and the skin. For example, E. coli lives in the colon on a permanent basis. Portal of exit sites include the skin and respiratory, urinary, gastrointestinal, and reproductive tracts. For example, a patient with the influenza virus may release pathogens from the respiratory tract when they cough. Modes of transmission include contact, droplet, airborne vehicles, and vectors. So you might contract an infectious disease by touching a table or object that was not properly disinfected. This would be an example of indirect contact. Portal of entry encompasses the same places pathogens exit from. A host's susceptibility to an infectious agent depends on its resistance to a pathogen. Factors that affect susceptibility are age and nutritional status, and the presence of chronic disease, trauma, and smoking. Remember, hand hygiene is the most effective way to break the chain of infection and control transmission of infections. So a patient is admitted to a medical unit for a home-acquired pressure ulcer. The patient has Alzheimer's disease and has been incontinent of urine. The nurse inserts a Foley catheter. You will identify a link in the infection chain as. So the correct response is C, catheter bag. The catheter is a portal of entry in the infection chain. The courses of infection by stage include the incubation period, prodromal stage, illness stage, and convalescence. The incubation period varies with disease and the interval between the entrance of pathogen into the body and appearance of first symptoms. The prodromal stage has more specific symptoms. Microorganisms grow and are capable of spreading diseases to others. So this is where the patient may be contagious or might be more contagious. The illness stage has the utmost specific symptoms, and the convalescence is when the acute symptoms of the disease have resolved. It may take a while for the patient to recover. For example, a patient with viral gastroenteritis would have an incubation period of 24 to 48 hours and a convalescence period of 12 to 60 hours. Normal flora are microorganisms that are considered good. Normal flora are these good microorganisms resist infection by releasing antibacterial substances and inhibit the multiplication of true pathogenic microorganisms. So if there is a disruption in the quantity of normal flora, a superinfection can occur. This can occur when patient is prescribed antibiotics, specifically a broad-spectrum antibiotic. An example of this might be Levaquin. The antibiotics destroy the normal flora, allowing the true pathogens to multiply. An example of a superinfection is oral thrush or a vaginal yeast infection. Examples of body system defenses include the urinary and respiratory tract. For example, we have cilia, small hair-like projections that line the respiratory tract. Their job is to track microbes and to sweep them up to be coughed out. Another example is the flushing action of urine. Urination washes away more microorganisms on the bladder lining and urethra. This is why individuals who hold their urine for long periods of time can develop cystitis or a urinary tract infection. Other defenses against infection include inflammation, vascular and cellular responses, exudates, tissue repair, and signs of local inflammation and infection are similar. So most often when you have an infection, you always have inflammation. But sometimes when you have inflammation, it doesn't necessarily mean you have an infection. So things that we might look at that could be different is if somebody has erythema, a redness of an area, and it might be warm to the touch and some discomfort. Like maybe if a patient has gout of their toe. But infection, they might have permanent drainage, they might have an elevation in temperature, or the redness might continue to grow or extend. Healthcare-associated infections occur in the healthcare setting as a result of the care they receive. This term was once referred to as a nosocomial infection. HAIs are among some of the most common and costly medical problems today, and they account for close to 90,000 deaths annually in the U.S. HAIs are secondary to invasive procedures, antibiotics, and breaches in infection control activities, such as poor hand hygiene, lack of wearing clean gloves, and improper use or avoidance of PPEs. Patients who develop HAIs can have multiple comorbidities such as diabetes or lung disease. They might be older or have had several invasive procedures at the same time, and the duration of stay can also promote HAIs. So for example, if somebody is discharged within 24 hours versus somebody who's been in the hospital 2 weeks. HAIs can be broken down into 3 types: iatrogenic, exogenous, and endogenous. An iatrogenic infection is caused by a procedure such as an IV insertion. An endogenous procedure is when the normal flora becomes altered and a superinfection occurs. The organism causing the HHI comes from within the body, and we just talked about that. An exogenous infection is caused by an organism that is found outside the body. A significant amount of diseases are induced by exogenous routes, such as gonorrhea, meningitis, tetanus, and syphilis. Patients transferred to various floors in the facility who are cared for by multiple caregivers are at risk for HHIs. This may be also due to the lack of continuity in their care. A patient who has had major abdominal surgery and has been in the hospital 7 days and has a urinary tract catheter and 2 peripheral IVs is high risk for an HHI. Patients who have had complex open procedures are at risk for HAIs. Many surgeries are now performed minimally invasive and as an outpatient procedure. Major sites for HAIs include surgical traumatic wounds, urinary and respiratory tracts, and bloodstream. Factors that influence infection prevention include age, nutritional status, stress, disease history, and treatments that compromise the immune system. Older people are more at risk for infections due to their medication regimes, disease history, and structural changes associated with age, for example, their lungs or their skin. And some women, as they get older, their urinary structures. Children are at high risk for infections due to their immature immune system. They haven't been exposed to enough infections to build their natural antibodies. Some people with stress, who have so much stress of even being in the hospital for long term with critical illness, can have exhaustion of their stress adaptation syndrome from high levels of continuous cortisone. The cortisone in itself, the high levels of cortisone, can actually suppress the immune system. But sometimes with high levels of continuous cortisone, it can actually exhaust the immune system or actually exhaust that adaptation syndrome. So some people might have adrenal insufficiency and may not be able to protect themselves because of that continuous high level of stress. Disease history. Does this patient have AIDS, leukemia? So their white blood cell counts, their neutrophils, their CD4 counts might be low, and this could predispose them to infectious diseases or opportunistic diseases. Some treatments or conditions that compromise the immune system are chemotherapy, immunosuppressant drugs like Humira. Some people take those for autoimmune diseases, psoriasis, inflammatory bowel syndrome. So they work, but they also work by suppressing somebody's immune system. So they're more at risk for acquiring infections. So your patient interview should include a review of the systems. And we know that a review of systems is the subjective information of the patient's body systems, their travel history, like West Nile and Ebola, those things when you go out of the country that we don't really consider, and their vaccination history. It's important that we talk about that in light of the resurgence of infections that were once obsolete, like measles and pertussis. So pertussis is whooping cough. If early detection is not noted of some of these infections, your patients can sometimes progress to sepsis, septic shock, or even death. So sometimes your subjective assessment and then your physical exam are very important so that you're not missing those subtle signs. So when you're doing your physical exam, what is the status of their defense mechanisms? Do they have intact skin? Is there a break in the skin? Do they have a pressure ulcer? Do they have an effective cough? Are they able to cough adequately to expectorate, their secretions? Are they a smoker who has smoked for many years? And so as a result, that cilia, that hair-like projections that are a defense mechanism, have they been eroded? For patient susceptibility, and we talked about that a little bit, and susceptibility we know means how high at risk are they for getting that infection. Medical therapy includes steroids and immunosuppressant drugs like the Humira. Steroids, we know, suppress our immune response. It's an anti-inflammatory, and so sometimes for short times it's okay, but for people who are on high doses or even over a long extended period of time, it places them more at risk for infections. So their clinical appearance, what do they look like? Do they look sick? Signs of symptoms of infection might be local or systemic manifestations. Local, we know, might just be the redness, the swelling. Is there drainage? What color is the drainage? Does it have a foul odor? And then maybe some of those systemic manifestations. Do they have a temperature? Do they have chills? Are they a little lethargic? Laboratory data that we might be looking at to see if somebody has an infection would be an elevated white blood cell count. A normal is somewhere between 5,000 to 10,000. So if it was over that and they also had these signs and symptoms of infection, then we could conclude that they most likely have an infection. Cultures, we can check their blood, we can check urine, we can check stool, we can check their sputum that they cough up. So you are caring for a patient who underwent surgery 2 days ago. On physical assessment, you notice that the wound looks red and swollen. The patient's white blood cells are elevated. You should So the best answer is notify the physician. So we can anticipate that we'll probably start antibiotics. First, we might get a culture. But yes, definitely our priority in this situation would be to notify the physician. So obviously risk for infection is our key diagnosis, but if the infection is already present, we probably need to consider possible complications from the actual illness. Dehydration, pain, or dyspnea, and we know that dyspnea means difficulty breathing. Or the psychological implications from the treatments we provide, isolation, immobility, or even sleep depression or sleep deprivation. So when we're planning, we're going to look at the goals and outcomes. Again, we know the goal is the broad, overarching, and then our outcomes are the smaller short term that's going to get us to the goals. They're going to be what we measure to see if we've achieved that goal. The common goals of care applicable to patients with infection include the following: preventing exposure to infectious organisms, controlling or reducing the extent of their infection, maintaining resistance to infections, and then also to have them verbalize understanding of infection, prevention, and control techniques, like hand hygiene, good overall hygiene, vaccinations. To remember to prioritize according to Maslow's hierarchy. In these patients, respiratory issues are probably going to be our highest priority. In regards to infectious disease, you might want to collaborate with an infectious disease physician or nurse. So health promotion activities might include teaching your patients about nutrition, support, rest, personal hygiene, physiological protective mechanisms, and recommended immunizations. For example, with nutrition, some things that we might encourage them is, in order to find out what the recommendations for them, they would have to, look at the U.S. Department of Health and Human Services. My Plate would be a great example of the correct nutrition for somebody. We could also collaborate with a dietitian. Paying attention to dietary restrictions with certain diseases and illnesses that they have. For example, people who have cardiovascular disease need to stay away from salt, high cholesterol, fat. Hygiene. We're going to reinforce good hygiene measures overall to our patients. Immunizations. We're going to educate our patients on the importance of vaccinations. We might refer them to the CDC's immunization schedule. And we need to also remember that immunizations or vaccinations are not our personal opinion. We base our practice on science and also based on what our affiliating organizations and associations like the American Nurses Association, the Institute of Medicine, what do they suggest? And I think that's kind of a big issue with some of our patients who are not vaccinating their children. So that may be an issue you come across. So you have to kind of put your personal opinions aside on that, and you have to go based on the science and what our organizations suggest. Sleep, we need to understand the implications of sleep impairment or deprivation in our patients who may have an infection or be at risk for that. We need to educate our patients on the required amount of sleep for their age and their condition. We need to talk about the methods of sleep hygiene to promote sleep, and maybe non-pharmacological methods that can induce sleep. Because remember, we're not going to use medications as our primary method. In the acute care environment, if we're treating a patient for infection, we have to also prevent other infections from occurring. We have to also ensure that we support their defenses, as we mentioned above, nutrition, hygiene, and sleep. But in this place, now that they're in the hospital, we have to somewhat do those things for them. Before, when it's promoting, we're educating and teaching them about how to do those things in the home to prevent them from it escalating and then getting to an acute care situation. Yeah. So in implementing care, when we're thinking about infection control, we need to think about medical and surgical asepsis. What would we be using in the situation? And we'll talk about that in lab in a couple weeks, but where would we use medical asepsis versus surgical asepsis? We need to control or eliminate infectious agents, control or elimination of reservoirs, control a portal of entry, and that would be our devices, our IVs, our catheters, our breathing tubes, our large central lines that we put in our patients who are critically ill. We need to focus on control of transmission, which might be like the hand hygiene that we learn, or the isolation precautions with the PPEs. So just some terms about asepsis. So asepsis is the absence of pathogenic disease-producing microorganisms. And then aseptic technique is going to be the practices and procedures that assist in reducing the risk of infection. Medical asepsis or clean technique includes procedures for reducing the number of organisms present and preventing the transfer of organisms. So examples of medical asepsis is going to be our hand hygiene, barrier techniques, and environmental cleaning. Surgical asepsis, sterile technique, prevents the contamination of an open wound, serves to isolate the operative area from the unsterile environment, and maintains a sterile field for surgery or a procedure. Standard precautions is the first tier of the prevention of transmission of infections. Standard precautions prevent and control infection and its spread. It applies to the contact with blood, body fluid, non-intact skin, and mucous membranes for all patients. So we need to make sure that we wear gloves if we're going to be coming in contact with blood, body fluid, non-intact skin, and mucous membranes from all patients. This also means that hand hygiene includes the use of an instant alcohol hand rub before and after providing patient care, washing with hands and soap water when they are visibly soiled, and then performing a surgical hand scrub when it's appropriate, and this would be in the OR. Hand washing is the act of washing hands with soap and water using friction, followed by rinsing under a stream of water for 15 to 20 seconds. And we also need to remember that that might deviate to other agencies where they might encourage you to wash your hands for 30 seconds. So disinfection versus sterilization. Disinfection is a process that eliminates many or all microorganisms, with the exception of bacterial spores from inanimate objects. This is going to be where we're cleaning the counters, when housekeeping comes in after a patient has been discharged. So we're going to disinfect all surfaces. High-level disinfection, which is required for some items such as endoscopes. And then sterilization is the complete elimination or destruction of all microorganisms, including spores. This is most likely going to be down in the operating room where there are some equipment that we reuse. They're actually going to go through a sterilization process. So infection prevention and control. So what are some other outlying things that we can do? So we can separate personal care items. We're not going to just throw them all into one bin when we're caring for them. We need to be mindful of that. When we're handling solid and fluid waste, we're going to use clean gloves. Okay? Wound cleaning. We're going to adhere to physician orders. Does the wound need to be cleaned once a day or twice a day? And what kinds of dressings do we need to use? And then we're going to also maintain meticulous wound care with it. So we're going to learn when we do wound care in a couple weeks that we're going to do it based on a sterile technique. We're going to use a sterile field and sterile gloves because we want to prevent the transmission of infectious pathogens. Patient education. We're going to educate our patients on their illness and how they may have got it, and some of the methods that they can do to prevent it in the future, and also methods that they can use to help facilitate their healing. We're going to talk to them about cough etiquette, isolation and isolation precautions. We saw in the video when we were watching for PPE that the nurse had explained to the patient's wife about why he was in isolation and a little bit more than that. But we're going to educate our patients and families about why they're in isolation, because sometimes that can be a high stress thing for them. They feel like maybe it's a little bit more than what it is. So you need to reassure them and you need to give them all the facts. Surgical asepsis. We're going to adhere to surgical asepsis, and not only that, we're going to know exactly what procedures require surgical asepsis for a surgical technique. And if you don't know, you need to make sure that you ask. So cough etiquette. Obviously, you're going to cover your nose and mouth with a tissue when you cough. Place a surgical mask on a patient if it does not compromise their respiratory function. We're going to perform hand hygiene after contact with contaminated respiratory secretions. And we're going to make sure that we stay away from somebody from 3 feet if they're coughing or if we are coughing. So isolation precautions, PPE. We're going to separate of all ill persons with a contagious disease. Okay, so this is typically not based on facility. I mean, we take our guidelines based from the Center of Disease Control or the World Health Organization. Now, how they implement those on a floor from room to room might be a little bit different. Okay? Usually there's a cart that will have the equipment that you need for each particular patient. We talked about standard precautions. So airborne precautions is going to be somebody who has tuberculosis or varicella. These patients are going to be put in a negative isolation room. Okay? The air in that room is going to be cycled, it's going to be filtered and exhausted outside versus in the internal ventilation system. You're typically going to wear a gown, gloves, and they're also going to wear one of those N95 masks that gives you a little bit of tighter fit around your mouth. Droplet, this might be a patient who has influenza. You're going to wear a surgical mask, gloves, and then a gown. Okay. Contact, these patients might have C. diff, or they might have an MRSA colonization. Then we're going to make sure that we wear gloves and a gown, especially if we anticipate coming in contact with some sort of fluid. In the term protective environment, that is usually with a patient who has had chemotherapy or somebody else whose immune system is severely compromised. There might be special things that we do for them. We might not let somebody who has an infection come into their room. We might not put flowers with standing water in them. Those are the things that are going to breed bacteria. We might not share equipment with them. They might have their own equipment. And we still might wear a mask and gown when we go in there. But it's a little bit different because we're not worrying about the patient giving us anything. We're worried about taking something for them. So a lot of times when our patients are in isolation, they might feel isolated or they might feel lonely. We need to make sure that we give them ample time, and we also need to make sure that we don't feel like we're rushing them. Okay? And then we know our isolation environment is going to include the PPE equipment, appropriate trash and linen for us to bag our stuff after we're done, and then patient transport. A lot of times we can take our patients out of the room if they're in isolation. It might be done at certain times of the day. It might be done in a more emergent situation. And we also have to make sure what kind of mask they need to wear when they're in the hall. Surgical asepsis or sterile technique prevents the contamination of an open wound, maintains sterility in the operating room, and eliminates all microorganisms, including spores. Examples of procedures that require sterile technique include urinary catheterization, central venous catheter insertion, sterile dressing changes. There are various differences from the operating room to the patient's bedside in regards to surgical asepsis. Okay? So typically when you go to the OR, there's going to be a larger surface area that's going to be sterile. Okay? Whereas in a patient's room, when you perform a sterile technique or a sterile procedure, only a small section will be set up to provide that sterile technique. Okay? So these next two slides are the 7 principles of surgical asepsis, sterile technique. And I need you to remember these, and I need you to study them, and I need you to be prepared for them when we start talking about sterile technique in a couple weeks. So a sterile object remains sterile only when touched by another sterile object. So for example, if you're wearing sterile gloves, you may touch another sterile object and still maintain sterility. But if a sterile object touches a clean object, the sterile object is now contaminated. Only sterile objects can be placed on a sterile field. If a non-sterile object or clean object falls into a sterile field, the sterile field is now contaminated. A sterile object or field out of the range of vision or an object held below a person's waist is considered contaminated. We need to make sure that we keep sterile items in our sterile field in front of us at all times. If we turn our back on a sterile field or leave the room, the field is now considered contaminated. We really don't know what happened to the field when we weren't looking or when we stepped out of the room. The sterile object or field becomes contaminated by prolonged exposure to air. Not necessarily am I giving you minutes or hours, but you just need to know that you can't have a sterile field set up in the morning and then use it in the afternoon. Okay? You need to make sure that you set it up and get right to your procedure. So there is a limit to how long a sterile field can be set up prior to use. We need to make sure that we don't cough, or sneeze over a sterile field. We also need to limit congestion to the area where the sterile field has been set up. When a sterile surface comes in contact with a wet, contaminated surface, the sterile object or field becomes contaminated by capillary action. So if moisture leaks or drops through the protective covering of a sterile packet or drops onto a sterile field, microorganisms can travel to the sterile objects. the field is now considered contaminated. So you have to set up a whole nother sterile field or get a whole nother sterile object. Fluid flows in the direction of gravity. To avoid contamination during a surgical hand scrub, you need to hold your hands above your elbow. This allows the water to flow downward and away from your hands and fingers. The edges of a sterile field or container are considered to be contaminated. A sterile field has a 1-inch border, which is considered contaminated. So you're allowed to actually touch this 1-inch border around a sterile field with clean or bare hands. But if you touch it with sterile gloves or a sterile object, the gloves or object are now considered contaminated. So exposure issues, and this is referring to needle sticks or body splashes into your eyes, into your mouth, into your nose. So patients and healthcare personnel are at risk for acquiring infections from needle sticks. So in addition, nurses and physicians, this could happen with a housekeeper cleaning a patient's room. There might be a needle line open in the wastebasket. Okay? So following the passage of the Needle Stick Safety and Prevention Act of 2000, all syringes and needles became needleless or equipped with a needle safety device. After use, all needles must be placed in a puncture-resistant container. The two most common infections transmitted by needle sticks are HIV and hepatitis C. When we use the word exposure, it may also refer to blood that comes in contact with your mouth or your nose. A healthcare worker must always report any needle stick injury. This is going to be determined by your affiliating agency. So after exposure, the patient or the source where the material came from should be tested for any infectious diseases. And access to testing the source is based on state law. So for example, in the state of Ohio, a patient must consent before complying with a source test, which means if they don't want to, they don't have to have their blood drawn or any testing done to determine if they have HIV or hepatitis C. After exposure, the employee must complete an injury report and seek care in the ER. If a patient declines or is unable to comply with source testing, the worker should be tested for hepatitis C within 48 hours. They should also be tested 3 weeks after that initial exposure. If the patient tests positive for hep C, the patient should be referred for continuing care. Unfortunately, right now, there's no post-exposure prophylaxis treatment for hep C. Patients should be monitored for the development of hepatitis. If a patient is exposed to HIV, they should be treated with exposure prophylaxis within 72 hours of exposure for 4 weeks with antiretroviral drugs. Individuals should be closely monitored for drug toxicity and follow up with their physician within 72 hours after exposure. So finally, evaluation. Have the patient's expectations been met? Do they feel protected? Do they understand how infections spread? Do they understand the measures needed to prevent the spread of microorganisms? For example, hand hygiene.